when you see unstable angina, you're going to treat it as if a patient is having an MI. They're treated very similar because that one is going to be a predisposal to your MI patient. So those are your three types of angina. So when you see stable and variant, they are both treated the same, okay? But variant can cause problems if it's prolonged, because if that vasospasm is prolonged, that muscle can die. Unstable angina can lead to an MI, so therefore there could be damage with that one as well. And knowing that nitroglycerin and rest does not relieve that one. But if a patient has stable, variant, unstable, or an MI, could you still put oxygen on them?
Yes.
Yeah, because you don't know if somebody's having stable angina until they get in and have another procedure done, performed, right? We don't diagnose, we wait for the doctors to diagnose. So, in other words, what I'm getting at, if anybody comes in and they're having chest pain, it doesn't matter whether it's stable, variant, unstable angina, MI, they're pretty much going to be treated as if they're having an MI because we want to decrease damage until they do further exams, further testing. Does everybody understand that?
Yes.
We just know that most people, when they have stable angina, after they have had other further testing, that we know that rest and nitroglycerin are going to make them better and there's not going to be any further damage. All right, so a patient comes in with an MI, and we know that our angina patients and our MI patients have very similar symptoms too, don't they? We just know that their chest pain is either not going to be relieved and it's going to last longer if it's an MI. It's not going to be relieved with rest or nitroglycerin and it's going to last longer. So we know that. So that makes it different, and we know that there's going to be death with an MI. Whereas stable angina, there is no death. So time is of importance with these patients having chest pain. And another way you know whether a patient is having ischemia or an MI, what quick test could be done to look at to see kind of where we need to go?
EKG.
An EKG, absolutely. It's a very, very quick look, and from there they're going to decide, okay, what other tests do we go to from there? Now, if they come in with injury, what tests would they like to have performed from the time they get through the door and get into the another procedural area? What do they want to get performed within 90 minutes?
The PCI?
The PCI, absolutely. That percutaneous coronary intervention, because the whole important thing here is get those vessels dilated so that they can deliver that oxygen-rich blood to that myocardium so we don't have as much death. So that's the whole purpose of that 90-minute marker there. From the time they get in through the door to the time we want to get them into a procedural area, get that started so that we can save muscle. That's the whole purpose. Get everything opened up when they do that percutaneous coronary intervention. So all that it can be is a balloon angioplasty where they'll put the balloon in and push the plaque back and then deploy a stent. And the stent's there to keep it open, because if you don't and you just angioplasty it, the plaque can cease back into the lumen of the artery and cause blockage. And if that occurs, then the patient will exhibit with chest pain again. And that would be something that would definitely need to be reported to the physician immediately after they've had that angioplasty if there's no stent. Okay? And the whole purpose of the stent is to prevent reclosure. Okay? We try to prevent the closure of the coronary artery. It's kind of like a support wall that you may have in your house that's very important to hold the ceiling up. So that's what the whole purpose of a stent is. Now, the biggest thing you need to remember about with the stents, though, is that the patients will probably be on antiplatelet medications because we don't want them to reocclude. And some of the stents actually are coated with heparin so that it helps prevent any more formation of blood clots. And so that's the whole purpose of the percutaneous coronary intervention, is to make sure those vessels get dilated so they can get more oxygen-rich blood to the myocardium so we don't have any more death. Because if we have death, what is that myocardium going to lose?
Oxygen.
Non-oxygen. It's going to lose the oxygen-rich blood, but if it dies, what is that muscle lost?
Function.
It's losing function. It's losing function, such as what we call contractility, right? We can't fix it. So that's the other thing. So kind of keep that in mind, that when you have an MI, if we don't get it fixed very quickly, that area will scar, and then there is no return of that contractility at all. So that part of the muscle is totally gone. Okay. All right. So other things they can do for the patient, say for some reason the PCI didn't work, they may have to go in and do what we call the myocardial revascularization. And all they're talking about there, they're doing exactly the same thing. All right. All they're doing now is using some type of graft to do a bypass with. And if you recall, the grafts can either come from the leg. I'll go back here. They can actually, this is the most common place, is the leg. This saphenous vein is one of the most common veins they use because we have multiple veins within the leg. So they can use that just to bypass that obstruction. Okay, they connect it to the aorta and then they'll go below where the occlusion is. These can be, a patient may be on what we call our cardiopulmonary bypass graft machine. They may be placed on that, which is where they bypass the heart and stop it. So that's total arrest. Open heart surgery is what we call that. They may have one where they still let the heart beat and they go through the thoracic cavity without doing a sternotomy, and they can fix a few grafts that way. The doctors may actually do a very minimal invasive, and they can do it endoscopically and do it that way. So all you need to remember about bypass surgery is they're bypassing the occlusion with either a saphenous vein or they're going to use the internal mammary. And all they're doing when they do bypass, or what we call myocardial revascularization, is they are just trying to reroute the blood flow, because we want blood flow into that area that has been damaged, okay, to keep some of it still, to keep it alive. Some of it's going to be damaged and there's nothing we can do because of timing. But the quicker that we get the blood flow there, the less damage the patient will have. Now, does everybody that has a heart cath go for bypass surgery? Not always. It depends on the occlusion, how much is occluded. Everybody that has an MI doesn't always have bypass surgery. It just depends. You may incidentally go for a stress test for a physical for work, and it shows some abnormalities, and then they may take you to the cath lab to look at those vessels and say, okay, well, there's really not enough there to fix. Let's just try to do it with the balloon, okay? And that works. But say they go in there and they say, oh, it's really occluded, we don't think the balloon or a stent's going to work, they may take you for bypass. They don't do a whole lot of the arrested heart surgeries like they used to. because it is very in depth. In other words, they do have to put of course, the patient's put to sleep, but the biggest thing here is they actually have to cut through the sternum to get to the heart. So they have been trying to bypass a lot of that because patients have more complications, especially with respiratory infections and things like that. So they pretty much have been going to the more of the minimal invasive types and the beating heart surgery. Used to be, this is just FYI, when they used to do beating heart surgery, they used to only could do one bypass. And that has changed, that has advanced considerably. So that gives them less complications when it comes to a beating heart, a minimal invasive surgery. They don't have as many complications as a patient that has the arrested heart surgery. And of course, the doctors I worked with, most of ours were arrested heart surgery. So they were put on the cardiopulmonary bypass surgery machine and everything. But they've gotten, a lot further in technology to where they don't have to do that as much anymore. And we don't see as many complications. Because if you think about that, if somebody has their sternum cut so that they can get to the heart, they have to actually wire that sternum back together. And if a patient gets pneumonia, they can actually pop those wires and have to go back to surgery and have those repaired. And not only that, if the sternum gets infected, sometimes they have to remove the sternum. So there's lots of different complications that can arise when they're doing the actual arrested uh, heart patients when they're on the bypass machine. And of course, they have more complications with possible bleeding and things like that. And this is just a picture of showing you what your patient kind of looks like if they've had a sternotomy type of surgery. And you look there, they have a big incision on their chest. It is actually the sternum is wired back together. Then they do a lot of inside suturing. Then they, at the end, they can glue or staple. They used to do a lot of staples externally on these patients. This one here is probably a glued, and then they got some steri strips on them. If you look at this patient, if you look and see those little blue wires that are kind of small, and you see a little adapter that's connected to them, they're white. That is pacing wires. So if a patient has a coronary artery bypass and the heart's been put to sleep, and then they stimulate it to beat again, and because the doctor has been manipulating that heart with their hands, it can actually cause the heart to become a little irritated. And normally, what we see happen with these patients in a long run, they'll have what we call atrial fibrillation that we'll talk about when we get into chapter 25. It's just because they've been manipulating that heart. And that's really not uncommon for us to see that arrhythmia rise probably within the first 48 hours on that patient. But the other nice thing about the pacemaker, this is FYI information, that when they have that, if for some reason the patient's heart is not putting out enough output, that amount of blood it ejects within that 1 minute, we can actually stimulate it through this pacemaker. Either we can speed up the rhythm and it will give us a better output. And so the heart has a little more time to recover as well. So there's a lot of benefits with this external pacer. Now, if you look down and you see those big old tubes coming out of the chest, one of those is for air and one of them is for fluid. Because they have manipulated the heart, sometimes there'll be some blood that will get into the pericardium area, and so we want to drain that out so we don't have compression of the heart. And so they'll use that. Or if for some odd reason, say one of the arteries was not sutured well and you see blood filling up in the chest cavity, guess where it's going? It's coming out into a chest tube. So we know if a patient is internally bleeding, not only by looking at vital signs, but we can look at our drainage. And patients may have to go back to surgery because something's not quite sutured, or maybe something came loose and they start bleeding. That's not uncommon. And you got to think about that. They may bleed more too, because when they're on that cardiopulmonary machine, they're getting a lot of heparin. Yes, they do try to reverse that, but sometimes it doesn't always work. And so the patients may bleed. And so that's another way for us to know if they're bleeding internally, not only by vital signs, but also by seeing it directly as well. So that helps us a lot. These patients, bless them, they look like train wrecks when they come out. If they've had the uh, normal arresting heart coronary artery bypass or myocardial revascularization, they look very, very sick, and they are very, very sick. Used to be years ago that they would actually stay in critical care 7 days when they first had their surgeries. And the funny thing is, they would actually go to recovery rooms in some of the hospitals. At St. Thomas, they never went to a recovery room. They came directly from the OR table to us, and that's where they were recovered. And these patients can be really, really sick. And I'll tell you a story that's really interesting about this. And you look at this picture and you see that patient's chest has been cracked, okay, or cut open, right? All right. Now, if a patient gets in dire distress, they do not, a lot of times, if they need to have CPR, they don't want you to do CPR on their chest because they're afraid that you can uh, mess up the sternum. But sometimes you don't have a choice, you have to. But we had a patient that was bleeding and bleeding really bad. And so we had called the doctor. The patient was spiraling very quickly. He comes in, he says, okay, I want the retractors, I want the sternum splitter. And we're all going, oh, good God. And so what they did was we opened the chest in the room. He said, okay, put your hand here. He grabbed my hand and he made me put my hand in the patient's chest. He said, okay, I want you to start squeezing, get in the bed. So I had to literally straddle this patient with their heart in my hand, and do compressions as we went to the OR to keep that patient alive. That's how bad it can get. So that was pretty interesting. That was fun. I was, thank God I had a lot of adrenaline going, or I probably would have passed out. So, but that was interesting. That was fun. I hated it for the patient. The patient survived. They did really well. So we were lucky. That's just FYI. All right. So the biggest thing with your post-operative patients, uh, treat the pain, treat the pain so that they don't get what? What do we not want them to get? What's the first post-operative respiratory disorder we see can develop with your patients?
Pneumonia.
Not pneumonia. What's the first one?
Oh, we went over that one too.
Is that atelosis?
The apoplecsis. Yeah, that can lead into pneumonia. So you got to take care of their pain so they can deep breathe and cough, use incendiary spirometers, and get up. These patients don't stay in the bed because they had open heart surgery. They get out of bed. Okay? It pretty much almost once they get stable, they're up. So they're going to be up probably within the first 12 hours of surgery, after surgery. Okay? And the decreased cardiac output, once again, like I said, because they can have decreased cardiac output, then they can actually use the pacemaker for that too on the patient. And we can give fluid, blood, whatever we need to give. And of course, there are always risks for infection, especially any incisional site. So these patients, if they've had an arrested, they're not only going to have the legs that may be using the vein incision site, but they may also have the sternotomy site as well. So we have to be on top of infection for those patients. Some other things that we can talk about with the patients that has MIs is your let's get our medication chart out and let's go through the medicines that these patients will get while we are waiting for them to have their PCI or maybe their coronary artery bypass. So we know when they come in, the whole overall goal is to restore the blood flow within that 90 minutes. That's our overall goal with anybody that has an occlusive disorder. We have to restore the blood flow. That is very important, period. We know, you all know you're going to administer oxygen immediately. You know you're going to be assessing the patient. You're going to be getting those vital signs. You're going to be doing your SPVR, your PQRST thing. You're going to be doing all of that.
Miss Mayonnaise?
Yes.
Quick question. What chart are we on?
The EMI medication chart.
Okay, the one that we were supposed to submit last week, but we didn't get around to it?
Right, exactly.
Okay.
All right. So we've done that. Then we know we need to, once we assess the patient, get the oxygen on them, we should be in the midst of, we've already got help, doctors on the way, we're getting our 12 lead ECG, and now we're administering medications. And we're getting an IV in so we can give our meds. What medication over the counter could a patient take if they call in and say, I'm having chest pain?
Aspirin.
An aspirin, absolutely, yes. All right. When it comes to your analgesics, which medication are we looking for the physician to order?
Morphine.
Morphine. And remember, when you're taking NCLEX, you already have your orders, okay? The doctor's orders are there. They may just say, okay, which one are you going to carry out first? So we have an analgesic, morphine. That one is going to be priority for managing pain. Because if you recall, pain, what do we release when we have pain? What's circulating?
Epinephrine.
The epinephrine, absolutely. You have circulating catecholamines. So your mechanism here is to manage that pain by reducing circulating catecholamines. So you want to reduce catecholamines. So we're reducing the pain because we're going to reduce the circulating catecholamines. So therefore, it's also going to reduce their anxiety. So what did we say that morphine will do if we don't allow catecholamines to bind to the receptors? What's it going to do to the overall arterial lumen?
Is it going to let it relax?
Yeah, it's going to relax. So that means it's going to do what? It's going to
Dilate.
vasodilatation is going to occur with morphine. So this is still part of the action. So if it decreases the constriction and we've got vasodilatation, what's it going to do to afterload?
Decrease it.
It is going to decrease it. There you go. So in your mechanism of action, you should have that it reduces circulating catecholamines. So it should cause vasodilatation. It should decrease afterload. And it's going to reduce the preload because the heart doesn't need to work as hard. So we don't need a whole lot of stretch. So it can reduce the preload as well. So if we have reduced afterload and preload, what did we do to the workload of the heart?
Decreased it.
We have decreased the workload of the heart. So therefore, did we decrease myocardial O2 consumption?
Yes.
Yes. So that's what morphine does when it vasodilates and it decreases the afterload and the preload. It has decreased the workload on the heart. So therefore, you have decreased myocardial O2 consumption. The heart doesn't have to work as hard. So what are some side effects that we should watch for with this analgesic of morphine? That's the only one you're going to have. Is morphine's the only analgesic we're going to have. So what's some side effects we should watch for with morphine?
Decreased respiration.
Absolutely. It's going to decrease respirations. What's it going to do to your blood pressure? Could the patient become hypotensive?
Hypotensive, yeah.
Yes, patient could be hypotensive. And because we're suppressing epinephrine, could they actually decrease their heart rate?
Yes.
Yes, so those are the side effects. We're going to see hypotension, the decreased respirations, decreased heart rate. So what would be your nursing implementation before you give morphine?
Monitor vital signs and monitor respirations.
Monitor those vital signs. Wouldn't you want to also make sure you're monitoring pain level and sedation level? And what are you going to tell the patient not to do by themselves?
Get up.
Get up. Yep. We need to make sure that they are calling for help. And your only example will be morphine sulfate or morphine. That is all you're going to have on that one. So that's your analgesic. And if you're not for sure, it's on 415 in your med surg book. And also in your pharmacology book, it's on 257 for your side effects. All right, the next drug that we're probably going to see the patient receive is probably a thrombolytic. Tell me why a patient may receive a thrombolytic.
To break apart a clot that they may already have.
Clotting.
Absolutely, because water most MIs cause from
A blood clot.
a blood clot. So they like to give these thrombolytics preferably within 30 minutes of arrival. Is that even feasible? Probably not. So we can give it up into the first 6 hours for the effect. So the mechanism of action for a thrombolytic is very simple. What is it?
Dissolve blood.
Dissolve blood clot.
Yeah. It's just going to dissolve that blood clot. It is just a clot buster, is what I call it. So it's just going to dissolve or burst the thrombus. And the whole purpose of it is for what? What's it going to do overall if we burst the clot? What have we just done to that coronary artery?
Gave it more dilation or more room for the blood to go through?
There you go. We gave it reperfusion. That's the whole purpose of the thrombolytic, is for reperfusion.
And did you say it was given 30 minutes in admission up to 6 hours?
We like to, realistically, the go is 30 minutes, but we can give it up to 6 hours.
Okay, awesome. Thank you.
So in other words, this is a short-term drug. We don't use this the whole time they're there, okay? This is only emergency use. You will see it given, but you as an LPN will not give it. It is given IV to the patient. You'll probably monitor the patient. Now, so this is just mainly to dissolve the clots, and it is, or burst them for reperfusion. That's their whole purpose. Now your suffix, what do you think your suffix is on this medication?
Lace.
ACE, ASE. Yep. What do you think your side effect of this medication is going to be?
Bleeding.
Bleeding, absolutely, because we're not allowing clots. Okay? So, what's going to be your nursing implementations by just looking at that? What are you going to be assessing your patient for at all times?
Safety.
For bleeding.
No.
Bleeding.
What?
Bleeding.
Bleeding, yes. You definitely need to be on top of their level of consciousness because they could bleed in the brain. What are some lab works that need to be drawn for a patient that is, or that you're going to monitor as the nurse?
PT, thrombo, INR.
Okay, INR. APTT, I heard.
PT.
Do you need to be on top of their platelet count?
Yes.
Yes, anything that deals with formation of clots or bleeding should be monitored. So you should have an INR, an APTT, a platelet count. What about a hemoglobin and a hematocrit? Yep. And also, what should you avoid when you give this medication? 24 hours after.
Venipuncture.
Any type of venipunctures. And also I'd be be on top of my IM injections to make sure they don't bleed, but IV definitely. Now there are some contraindications that you need to be aware of when they're giving this medication when they may not give it. You can just put this over to the side. A lot of times if a patient has had a recent head injury, because we could cause them to bleed more. If a patient has had a stroke in the past year, because it may have been an actual bleed in the brain, not a clot, and so we could cause them to bleed within the brain again. If they are pregnant, it is contraindicated with people that are pregnant. And of course, we wouldn't want, it's going to really depend though. If it's life-threatening, they're going to get it. But these are some of the things we should be aware of that we kind of want to make sure the doctors are aware, or if they've had surgery in the last 10 days, because we don't want them to bleed to death from those. So the thing about thrombolytics, though, they're very expensive. They are very expensive medications, thrombolytics are. So these are emergency use only. Out of place is one of them. Out of place. That's your ALTEPLASE. Believe it or not, that's how you pronounce it. Out of place. ALTEPLASE. And then the other one that we see used is the TPA, which is the tissue plasminogen activator. That's the one that is most commonly used, and it's very expensive. Very expensive. But those are the ones that you're going to see used. Now, in combination, once they've gotten the thrombolytic and we've burst the clots up, then the patient will be placed on what we call the anticoagulants, because we don't want them to develop other clots. So now they'll go on what we call the anticoagulants. So the anticoagulant that we will see given first is going to be just regular heparin, okay? Which will be just regular heparin. Because the whole purpose of that one, the anticoagulants, is to prevent the clot from forming again. And these can be used either IV or sub-Q. So you're probably going to see heparin. That's one of the examples. Now, so they're preventing the clots from forming. So what would be a side effect that we would worry about with just heparin? Bleeding. Absolutely, bleeding. So then tell me how you would monitor your patient for bleeding as the nurse. What would be some things that you should be assessing on the patient?
APTT.
Say it one more time.
Monitor the daily APTT.
Okay, we're going to monitor the APTT daily for heparin, absolutely. How are we going to know if the patient's bleeding?
You're gonna look
For bruises.
Okay, bruising, right? Increased bruising.
Petechia.
Petechia.
Coffee ground emesis.
Okay, any type of bleeding. They could have bleeding gums. What about their stools or their urine?
Tarry stools.
Yes, the black tarry stools, or they could have hematuria. Now, what should the client do about that bleeding?
Report it.
They need to report it, absolutely. And these, when they're in the hospital, they will start out with the IV heparin. So they'll get the thrombolytic. Let's burst the clot. Then they'll go on a maintenance of heparin that they'll give IV to prevent any further clots. Okay, while they're in the hospital. So that'll be the actual heparin. Then, when they get ready to go, what's the antidote for your heparin that needs to be at the bedside?
protamine sulfate.
Protamine sulfate. So you as the nurse, as a nursing implementation, must have protamine sulfate at the bedside or available. It doesn't have to be at the bedside, but you need to know that that's what you need if the patient starts to bleed. Okay? Now, another type of heparin that the patient will probably go home on that will prevent further clotting, it does the same thing, is this low molecular weight heparin. So we can see some low molecular weight heparin. And that would be your what? Which one do you think you're going to use for low molecular weight heparin?
Enoxaparin.
Enoxaparin, yes, the ENOXAPARIN. And pretty much all it's doing, it actually is preventing blood clot formation as well. It just works in a different area, okay? You're still doing the same nursing implementation. You're still monitoring for bleeding. The patient should still report abnormal bleeding. Now, what lab should you monitor more closely with enoxaparin? Because it's low molecular, we're not going to see as much bleeding. So what should be monitored with that patient?
The platelet count?
The platelet count. It affects the platelets more commonly because it is low weight. How is this medication usually administered?
Subcute.
Subcute. So this is our low molecular weight heparin that the patient goes home on, that they can administer to themselves, or they can have a home health nurse come in and do it in subcu injection. So you need to know as the nurse, what are you going to do every time you go in to give subcu injections? Are you going to give it at the same site?
No rotation.
Okay, we're going to rotate our sites. Then, because it comes in a pre-filled syringe, what should remain in the pre-filled syringe, as you as the nurse should know as well as the patient?
The air bubble.
Yes, we do not remove the air, okay? The air remains. So as the nurse, we're still monitoring for bleeding. We're still asking the client to report abnormal bleeding. We, as the nurse, are going to make sure platelet counts are being monitored. We, as well as the patient, should know this will be a sub-Q injection, which goes into fatty tissue. We, as the nurse, as well as the client, should know we rotate sites. We, as well as the client, should know that the air bubble should remain. Now, what over-the-counter medications are you going to instruct your patients to try to stay away from?
NSAIDs.
NSAIDs.
NSAIDs, and what else?
Isn't there? I'm not sure.
Aspirin.
Aspirin, but the funny thing is, these patients are probably going to be on aspirin as well as a anticoagulant. The main thing here is you just don't want them taking extra aspirin, okay? If they are just on low molecular heparin for like blood clots in their legs, the aspirin definitely needs to be taught to them. But because this is with an MI, the patient will need the aspirin. So we don't tell them as much about staying away from the aspirin as we would if it was just for blood clots, okay? Or say the patient was going home on it prophylactically to prevent blood clots. So they will probably, you're going to see them on aspirin with this medication with an MI because there's a whole purpose of it, okay? So what is your suffix of this heparin and low molecular heparin of enoxaparin?
Would it be RAN?
Parin, P-A-R-I-N. P-A-R-I-N is going to be your suffix to recognize it as being a heparin. Okay? Now, the next drugs that you may see your patient, well, the patient's going to be given is an antiplatelet. What's the whole purpose of the antiplatelet medication?
To keep the blood from clumping together.
So we want to prevent the platelets, right,
Yeah, the platelets
from clumping together to form a clot. So that's the whole action of an antiplatelet, is prevent the platelets from clumping together to form clots. In other words, platelets are very sticky, so they like to stick together. But if they get an anticoagulant, then we can prevent them from clumping together to form the clot. And so that's going to be one of those medications they can take over the counter if they have it at home. If they call and they say they're having chest pain, refer them to go call 911 and chew an aspirin. So you got your antiplatelets. So what could possibly be a side effect of antiplatelets?
Bleeding.
Bleeding again, right. So you as the nurse, also GI upset is another one that we can see as a side effect besides bleeding is GI upset. So as a nurse, once again, we're going to be assessing for bleeding. The patient should report bleeding. We should know that the patient needs to chew the aspirin. It is an adult form aspirin, so it's going to be like 325. Now, what if they say, well, I don't have any adult aspirin, I only have children's aspirin?
They can take.
They still take it. Just take 4 tablets, okay? But they still need to chew it because you get a quicker effect. So that's what you're going to teach the client, and just make sure that they are going to chew it. That's going to be very important when it comes to the antiplatelets. And that's just to reduce the platelets from forming clots. And your example there, we already said, is going to be aspirin. Then there is another one. And the other one is the one that they will get post-PCI. and that's the calpitgrel is the other one. Clopidogrel. That's Clopidogrel. And the way you recognize the calpitogrel is through the GREL as an antiplatelet. So you can recognize it as GREL, and that's the one they'll go on post PCI. So you've got two examples of antiplatelets. One's an aspirin. Okay, and the other one would be post PCI. The calpitogrel. Okay, Clopidogrel. And your suffix for that one is GREL. So that kind of takes care of those. All right. Then other medications the patients may be on is what we call vasodilators. Which ones are your vasodilators that are on your chart?
Your nitrate?
Your nitrates, absolutely, the nitrates. Now, my question is, though, could you give this patient a sublingual nitrate or a spray in an acute attack?
Yes.
Yes, but are they going to get relief from it?
No.
No. The whole purpose of the nitrates with the MI, they are going to receive it more likely IV. So that means you as the LPN will not titrate this medication for an effect. In other words, you will be assessing the patient for reoccurrence of chest pain, and then you will let the RN know. So in other words, the nitrates, these vasodilators, they could be given sublingual, they could be given spray. We normally see once the patient has already had a sublingual or spray and they get no relief, they will be placed on IV nitro. What's the whole purpose of the nitroglycerin? What's its action? What does it actually do?
Doesn't it cause
It vasodilate.
Okay, it causes vasodilatation, but what is that vasodilatation?
It reduces the oxygen. Right? Something along those lines.
Okay, so what it's actually doing when it vasodilates, it's relaxing the smooth muscles of that artery lumen, right? It's relaxing the smooth muscle of the arteries and the veins, so it's opening it up. So when it opens it up, is it opening that lumen? So the lumen is going to increase in diameter. So you got an increase in diameter. So when you vasodilating, what are you doing with your supply of the blood to the myocardium?
Increasing.
You just increased your supply. Okay, if I increase the supply, what's it do to pain?
Decrease.
It will decrease the pain, and what's it going to do to the workload of the heart?
Decrease.
Decrease, absolutely. So what you're doing is you're opening up the lumen, okay? When you open up the lumen, you're supplying more blood to that myocardium. So you have increased the blood flow, all right? And you've reduced the pain, and you have reduced the workload of the heart. So what did you just do by increasing the blood flow with more blood? What did you do to your O2 myocardial consumption?
Decrease.
You decreased it. There you go. Very good. All right, and with your nitrates, when do you hold for blood pressure? What is your nursing implementation when it comes to blood pressure?
Would you hold it if BP is under 90,
Yes, under 90.
90 or less.
Yes, 90 or less. All right, so that means you have to take a vital sign, a blood pressure, before you administer the medication. So if I have to take a blood pressure before I administer the medication, what could be a side effect if I'm coding it for a blood pressure less than 90? Hypotension. Hypotension, absolutely. All right. Please remember also these nitrates start to work within about 1 to 2 minutes. They work very rapidly. And because we're vasodilating everything, what could be a side effect the patient may complain of that's very common?
Headaches.
Headaches. Yep. All right. Now, the other thing with this one, when it comes to teaching, with nursing implication, we're monitoring blood pressure. We also should monitor apical pulse because it can affect apical pulse as well. So if we are teaching a patient to take nitrate sublingual, or if we're administering, how should we administer?
Under the tongue.
Okay, it's sublingual or it could be spray. So client teaching, we tell them it goes under the tongue, the first sign of pain, right? And should they be moving around or should they sit down or lie down once they take it?
Ready to sit still.
Right, they need to be sitting or lying down after they take it, okay? So when they take it, how are you going to instruct them to take it when they're, as far as frequency?
They can take one every 5 minutes, but up to 3.
There you go, one tablet every 5 minutes up to 3. All right, but if they are a known MI patient, when should they call 911?
After they take the first
After
one.
the first one.
After they take the first one, because time is muscle. Very good. What medications are contraindicated for patients if they're of the male consent, male gender?
Erectile dysfunction medicine.
Erectile dysfunction medication. So we need to make sure with client teaching they are aware of that because they're the ones that are going to die during a massive sexual intercourse time when they have taken a Viagra and they have taken their nitroglycerin so that they don't have chest pain and then they die on top of their partner. Those are the ones that happens to. Also, they should avoid alcohol because alcohol vasodilates as well. When should they replace it? What should they be taught about replacing the nitroglycerin?
Every 6 months.
Every 3 months.
3 months.
Every 3 to 6 months. I think your book says every 3. Mm-hmm. All right. And should they carry it at all times on their person?
Yes.
Yes.
Okay. And should it be in the original container?
Yes, ma'am.
Yes.
Yes. So when you're administering nitroglycerin to a patient, you will have the little brown bottle because light will break it down. You do not take the nitroglycerin out of the bottle and put under the tongue with your hand. It will dissolve. And not only that, if you do that, it's going to go through your hands. Okay? What you do is it has a cap. You'll take the cap off and then you'll place the tablet in the cap and then you would put it under the patient's tongue that way. Okay? So that's how that's going to work. Now, another medication that you can give the patient that could be a maintenance medication would be what that would decrease the work of, what is your suffix of nitroglycerin?
Nitro.
Glycerin. Suffix, glycerin's the last. Yeah.
Yeah, that makes sense.
All right. And another drug that can actually decrease O2 myocardial consumption that a patient may be placed on as a maintenance type of medication, what could it be? What else could they be placed on?
A beta blocker.
A beta blocker, yes. How do you recognize your beta blocker? What's your suffix?
OLOL.
OLOL, right. Okay. So, how does a beta blocker work? How is it going to decrease the oxygen demand and decrease the workload on the heart? That's the whole purpose of these drugs, is to decrease oxygen demand of the myocardium and decrease the workload of the heart. How do they do that?
Well, it vasodilates,
Blocking
but it blocks the SMS.
epinephrine.
Okay, right. It is going to block the release of those catecholamines of epinephrine and norepinephrine. All right, so we're blocking the release of catecholamines, CATECHOLAMINES. So if we're blocking the effects of catecholamines such as epi and norepinephrine, what is it going to do to heart rate?
It's gonna bring it down.
Okay, it decreases the heart rate. If I decrease the heart rate, what's it do to contractility?
It's gonna decrease it.
So if I decrease heart rate and decrease contractility on a heart that's working very hard, I will decrease its oxygen demand and we will decrease its workload. And because we are blocking that rhythm, that epinephrine, we can decrease risk for arrhythmias. So that's another nice thing with beta blockers. Because what's one of the most common complications with a patient having an MI?
Is it the cardiac arrhythmias?
The cardiac arrhythmias, absolutely. They can have tachycardia. And look, if we give them a beta blocker, we can prevent the tachycardia, which is an ominous sign for somebody having an MI, because that means the heart's working harder. So if we can block that effect, we can slow it down. It doesn't work as hard. And so we decrease its oxygen consumption and we can decrease that risk for that arrhythmia. All right. So now we have, overall, we have decreased oxygen demand and decreased the workload of the heart. What are some side effects that we should look for as a nurse?
6B.
What are our 4Bs?
Bronchospasm.
Bronchospasm,
Bradycardia.
bradycardia,
Low
Pressure.
blood pressure, and
Blood glucose.
blood glucose. And what else do we need to add on there for men?
Erectile dysfunction.
Erectile dysfunction or sexual impotency. Okay? All right. So as the nurse, what should we be doing when we're giving beta blockers? What first should we do before we give the beta blocker?
Check the blood pressure.
Check the blood pressure and the apical pulse. Absolutely. When do we hold it?
If it's less than 60 beats per minute.
Okay, heart rate less than 60 and systolic blood pressure less than 90. All right. Should we make sure the patient is changing position slowly? Should we tell the patient that as well?
Yes, ma'am.
Change positions. All right. Should you be assessing lung sounds?
Yes.
Okay.
Yes. All right. And if you have a diabetic patient and you are teaching the patient as well, should you be monitoring blood sugars and expecting the patient to monitor blood sugars?
Yes.
Okay. And when would this medication be contraindicated? What kind of respiratory patients?
Asthma.
COPD and asthma.
COPD and asthma. Absolutely. All right. You also need to make sure you teach the patient that impotency can occur. And what's your example of this medication that you're probably going to see given to the patient?
Atenolol.
Atenolol. Yep, atenolol is probably going to be the one that we'll see given. Very good. Y'all know that drug very well. Good. All right, now let's look at one of the things we said. What was their most common complication that we'll see develop that could be life threatening?
The cardiac arrhythmias.
The cardiac arrhythmia. So now you have another one on your drug chart that says antidysrhythmics, right?
Yes.
Yes.
Okay, so the one that we want to think about, the one that we're going to look at here is for, remember, we have tachycardia, which is ominous, but we're going to take care of that with bradycardia. The other ones that kill are ventricular arrhythmias. So any type of ventricular arrhythmia is what we're going to be treating with this antidysrhythmic. So our specific drug that we're probably going to use with this MI patient, your specific classification is going to be the potassium channel blocker. The potassium channel blockers. That's going to be the drug of choice because we see these patients have a lot of ventricular arrhythmias. And this drug is actually located in chapter 16, and it is on page 310. And if it's a potassium channel blocker, that means it's affecting the way potassium is moving in and out of the cell, okay? So this is actually affecting potassium. Where do you think it's actually keeping the potassium, inside or outside of the cell?
Outside.
Outside.
It's going to keep it inside, right? Because if you keep the potassium inside, what can't fluctuate in to make it contract as much? If I have more potassium in there, I can't have as much space for calcium. So what we're doing here is when it's affecting the potassium, it's going to stay within the cell, and it's going to do what we call relaxation. It's going to relax that cardiac cell so it doesn't become excited. And so what it actually does, it does what we call prolongs, Prolongs, like R-E, and then polarization, REPOLARIZATION. So it's going to prolong repolarization. That means it's prolonging relaxation. Now, if it is relaxing that cell, what would be a side effect we may see occur? If everything's staying nice and relaxed, what would be a side effect you may think the patient may exhibit with this medication?
Would it be hypotension?
Hypotension. This medication can be given PO or IV. You don't have to remember that, but it can cause hypotension. So nursing implementation, if it causes hypotension and it's affecting your fluctuation of calcium getting inside the cell, so what should you monitor before you give it?
Vital signs, baseline vital signs.
Especially which two?
Heart rate and blood pressure.
Blood pressure and heart rate, and also they should be on a cardiac monitor. So they should be on a cardiac monitor for this one. We may have to give potassium supplements, and you want to teach your patient they need to replace potassium in their diet. And what food or juice or fruit should they avoid if they're taking the oral form?
Grapefruit.
Fruit juice.
Yep. And what is our example of this drug?
Amiodarone.
Amiodarone. Absolutely. Very good. All right. And then, of course, because we know what is our most common cause of our coronary artery diseases? What's the most common cause of any of these diseases? If it's
Atherosclerosis.
Atherosclerosis.
atherosclerosis, so of course this patient's probably going to go home on a statin, right?
Miss Manners, I have a question.
Yes, ma'am.
Yes, go ahead.
I have a side effect for amiodarone, like lung toxicity. So
Yeah, pulmonary toxicity is another side effect that can occur, yes. All right, so we know that statins or HMG CoA reductase inhibitors, y'all remember that? That's the actual enzyme that's being inhibited. So, in other words, the action of a statin is we're inhibiting the manufacturing or we're promoting the breakdown of what? What are we inhibiting? The manufacturing or promoting the breakdown of? Cholesterol, absolutely. Which cholesterol are we removing from the circulating bloodstream when we give a statin?
The LDL.
The LDL, because they're the bad boys. All right. Where should cholesterol be? Less than what?
200.
200. Where is LDL?
Less than 100.
130.
130 desirable. I heard somebody say less than 100. That is correct. All right, and know that statins are going to be the first line of choice when it comes to atherosclerosis. All right, so with nursing implementation, when is the best time to give it?
Evening or night.
Evening or night.
Exactly, evening or night. And tell me why.
because it's the peak of production of
It's
cholesterol.
when cholesterol is the highest.
That is correct. That is when cholesterol synthesis is at the highest. So that's the reason it is given at bedtime. All right. Before it is given, what should be monitored and monitored probably every 6 months?
Liver function.
Liver function. So when you put that, you want to put monitor ALT, AST. And in parentheses, you can put liver functions. So we're going to tell the patient they're going to take it at bedtime. Excuse me. They may ask you why. You know why. All right. Now, we're monitoring liver functions, ALT and AST. What should the patient report if they start seeing what kind of symptoms, if there's liver involvement?
Yellowing of the skin and eyes.
Yellow of the skin?
Eyes.
Muscle pain.
Okay, not muscle pain. Muscle pain doesn't go with liver.
Clay colored stools.
Thank you. Clay-colored stools. Absolutely, Wilkema. What else changes color?
The urine is darker.
There you go. The urine becomes dark. So they need to report yellow skin, the sclera of the eyes, clay-colored stools, and dark-colored urine. That's telling us something's wrong with the liver. All right. What else is important that it could be a big problem for a patient that we should monitor for and the patient should report?
Muscle pain.
Muscle pain or that malaise, right? So if they're having that, what is a side effect of the statin?
Myalgia.
Myalgia, which is the muscle pain, which is caused because of what? What is happening? What's the whole significance behind the muscle pain?
The skeletal muscles are pulling from the bone.
You're actually having skeletal muscle breakdown. The muscle itself is starting to break down. Okay? So that's very serious. That's that ribomyolysis. It does not go away. It's permanent. Once it's there, it's there. We try to prevent it because what are we going to tell the patient to stop doing immediately?
Stop the
Stop
medication.
taking the
Yeah,
medication.
just stop the medication and we'll get back to you. We'll let the doctor know. You as a nurse can stop that medication. All right, is there any juice or fruit I should not be taking? What are you going to tell the patient not to take?
Grapefruit juice.
Grapefruit juice.
Yep, grapefruit juice. It will interfere, right? It will potentiate the medication. Okay, there's your chart. Did everybody get everything they needed for their chart? It will be due at 2:15 to 3.
For Miss Manners, for the example for the statins, do you want us to put atorvastatin?
You can put whatever one you want to.
Oh, okay, awesome.
Because you're going to recognize it as what? The stuff it. So you can use any of them you want to on that one.
Will we put anything about like the eye exam?
Is that anywhere in the book? I don't recall it being in the book for eye exams. Let me go back and look here. I don't see anywhere where it talks about eye exams. So we'll stay away from that, okay? If it's not in the book, I'm not going to ask it, and I'm not going to, because I don't see anywhere in the book that it talks about eye exams, okay?
Miss Manners.
Go ahead.
Hey, this is Erica. I stepped away when we were going over the antidysrhythmics. What's the side effect of it? I didn't get
Hypotension.
Hypotension?
Hypo, yes, ma'am.
Okay. Thank you.
And that's also in your drug book, in your pharmacology book. Okay, or pulmonary toxicity as well with that one, Erica. So that's your drugs, all right? That the patient, so when they first come in and they're having an MI or angina, oxygen goes on, right? And then we're probably going to give them that aspirin, chew it, right? Because we want that antiplatelet effect because most MIs are caused from a blood clot. So if we can keep the platelets from clumping, we want them to do that. Then with our MI patient, because we can give a nitrate, right? It's probably not going to relieve that patient, but we can still give it because we want to open up those vessels and get that blood flowing in there, right? Because that can help reduce some of the discomfort. But it's not going to completely relieve it with an MI patient. So we want to make sure we get an IV in very quickly because now we got to progress to something that's going to be more potent to decrease that oxygen consumption and give us more dilatation would be that morphine so we can decrease those circulating catecholamines and slow the heart down so it doesn't work as hard and we can decrease the O2 oxygen consumption. And then we're going to realize, well, we know that most of our MIs are from a blood clot, so they're probably going to give them that thrombolytic, okay? And that's just to burst the clot up so we can get reperfusion. Then we know incoherence with the thrombolytics once we've given that because that's going to be just an emergency use drug. They're going to be placed on probably an IV heparin for a while so that they don't form any additional clots, right? Then we're going to whisk them off and hopefully get them to the cath lab and get a PCI done. If that doesn't work, then they may have to have myocardial revascularization done. And then, of course, because the heart within the first 48 hours can become irritated, they may have to be placed on an antiarrhythmic medication. And one of the arrhythmias that we see is ventricular fibrillation, ventricular tachycardia, And so they go on that potassium channel blocker amiodarone. Now, if they're just having sinus tachycardia, they're probably going to put them on the beta blocker as their antidysrhythmic. Then also when they get ready to go home, they are probably going to be placed on statins because we know that most coronary artery disease disorders are caused from atherosclerosis. That's our number one. Also, could some of these patients possibly benefit from an ACE inhibitor?
Yes.
Yeah, because if you give an ACE inhibitor, it's vasodilating, so it can decrease the afterload and it can also decrease the O2 consumption as well. If it keeps that aorta nice and open, then we get good contraction from that left ventricle. It doesn't have a lot of opposition, and we can feel that aorta. And remember, what comes off of that ascending aorta that feeds the myocardium? Two arteries. What are they?
The coronary arteries.
The coronary arteries, the left and right coronary arteries. So they may give an ACE inhibitor for that fact, for the patient, just to keep the vessels nice and opened as well. Then there's some other things that we'll do for this patient when they come in and before they get ready to go to the cath lab, if we don't get them there yet, and say the cath lab is very busy. What is some other things that can decrease myocardial oxygen demand on the heart as well?
Oxygen?
Something simple. What are we initially going to keep the patients on to decrease that
oxygen?
Decrease myocardial oxygen demand. Now, this is even simpler than oxygen. What's on this slide right here at the top?
Rest.
Bed rest.
Bed rest. They're going to be placed on bed rest. They can use a bedside commode, and that is it. That will decrease the myocardial oxygen demand as well. Another thing that we do too to help these patients so that they don't have problems with their heart is we will give them stool softeners so they do not strain when they go to the bathroom, because they can have what we call a vagal response and they can pass out. So they'll be put on stool softeners as well. Now, when they get ready to go, if they're diabetic, then we need to make sure they're controlling their what before they go home or while they're in the hospital. What do we need to make sure we're controlling?
Their glucose.
Their blood glucoses, because that can damage the arterial lumen as well. We also want to make sure that they're getting the appropriate diet so that they can start losing weight. So these are some things we're going to get them started on and then make sure they progress toward. So we'll put them on a low sodium diet. They will be on, of course, low cholesterol, low fat. And they probably need to eliminate caffeine. Why would we want to eliminate caffeine in a cardiac diet?
Because caffeine speeds up your heart.
Yes, it speeds up the heart rate and it causes what else?
Vasoconstriction.
Vasoconstriction, absolutely. Now, what if the patient, though, is exhibiting with the complication of heart failure? What might we restrict on that patient?
Fluids.
Fluids, yeah. But most patients, once they are getting over the initial injury, during the injury, though, we still want to put them on bed rest, okay? But after the initial injury, we would definitely want to get control of their glucose if they're a diabetic patient. We know they're going to need to be on this low sodium, low cholesterol, low fat diet, no caffeine. We know that's going to happen. That is what they're going to go home on, okay? Also, while they're in, if they have any complications of left heart failure, they're probably going to be on a fluid restriction as well. And they may or may not go home on that fluid restriction. It depends on how severe the left-sided heart failure is. So those are just some other things that we can see occur and be done for this patient. But the main reason the bed rest is there is to decrease that myocardial oxygen consumption. Also, what if you got a patient that's had an MI and they're doing pretty good, and they decide that they want to get up and ambulate in the hallway? Okay, they're ambulating in the hallway, and then all at once they start having chest pain. What are you going to do with them?
Immediately sit them down.
Stop whatever they're doing, so that we can decrease that workload of the heart. And please remember, these patients are going to be administered stool softeners, because we want to prevent straining with these patients, because a lot of times, like I said, it can cause arrhythmias if they strain. The other thing, the reason we like the stool softeners is because it can actually, if they are struggling to have a bowel movement, it can also trigger ischemia as well. With the foods on that low sodium diet, remember, milk has a lot of sodium, a lot of your dairy products. You want to stay away from processed foods, a lot of the condiments. Anything that's canned, they need to stay away from. They need to do fresh vegetables and fresh fruit. Those are the best. Um, cheese is very full of salt, so they need to stay away from that and a lot of the soups.
Miss Manners?
Okay? Yes, ma'am.
If they can't get the very fresh vegetables, frozen is okay too, right?
Yes, frozen.
I know if you can.
Yeah, frozen will be fine. All right, let's take a 10-minute break. I'm sorry, I didn't realize it was 1:20. Let's take a 10-minute break and come back at 1:30, and we're going to finish up this chapter.
Hi, Miss Manners.
Yes.
So maybe we need to submit the myocardial infarction drug chart. It's still closed.
The MI cart is closed?
Yes, MI medication chart.
Yeah, it probably doesn't open till 2:15.
Oh, okay. Thank you.
Yeah, it probably won't open till 2:15.
When will close? When will be closed?
3 o'clock or 3:15.
Okay, thank you.
Uh-huh. If anybody wants to drop in the box, you can do it now. I have it open. You should be able to drop till 3 o'clock, 3:15.
Hey, Miss Manners, can I ask you a question right quick?
Uh-huh.
Okay, so I hear we're talking about, I know we're talking about MIs, and I was wondering, because I know some of them is occlusive, but could you be anemic and because you don't have enough oxygen-rich blood or blood volume traveling, could that also cause an MI?
It could cause chest pain.
Okay, all right,
Yeah.
thank you.
Uh-huh. so let's look at an overview of our myocardial infarction again. So Shakita, you get the first question. Are you with me?
Yes, ma'am, I'm here.
Okay, so you get to do the first question. Okay, we got a patient. This is an MI patient, so everybody listen up. They're 46. He's an accountant. He has a strong family history of heart disease. He's pretty much sedentary. He's 10% overweight. He's getting ready for work. He suddenly feels weak. He's a little short of breath. He has pressure in his mid-sternal area. His wife finds him clutching his chest and sitting on the bed. Okay? After 10 minutes, he tells his wife it feels like an elephant is sitting on his chest. Now, your question is, why should his wife call emergency medical services immediately? He's clutching his chest, sitting on the bed, and he feels like an elephant sitting on his chest. So why should his wife be calling medical emergency services?
Because of the chest pain, the crushing chest pain.
Yep. And what's the importance of this? Why would we want the paramedics there? What are they going to be able to give him very quickly?
The nitrostat or the morphine.
Okay, but what is that for him? What is that? When you're giving any kind of intervention, what is that? Is that a treatment? So the whole purpose is the reason she needs to call the 911 services is because we want prompt treatment, right? Prompt treatment of that patient. And should they ever drive themselves to the ER or a family member?
No, ma'am, they shouldn't.
No, absolutely not. Okay. Okay, Marquita, are you with me? Marquita?
Yes, I'm here.
Okay. So now the patient is in the emergency room and he has been diagnosed with an MI. Now he's having the following test done. Tell me why. Why is he having a echocardiogram?
To see the activity of his heart.
Okay, what would they be looking at for the ECG to see that it's an MI? To diagnose an MI. What's going to be significant on that ECG?
Like they'll be seeing like any dysrhythmias and stuff like that.
Well, not the dysrhythmia. How would we know if a patient's having injury or ischemia? What are you looking at on that ECG?
Like the rhythm of the heart and like heart damage and stuff.
Somebody help her out.
Is it the 12 views of the heart?
We're looking at the 12 views, but why are we looking at an ECG? It's a quick view for what?
You're gonna see any deviations in the ST segment.
Thank you. You're looking for that ST segment elevation for an MI. That's what we're looking at with the MI. All right, Marquetta. The next one is cardiac troponin. Why are they doing a cardiac troponin? This one kind of has three parts to it. You're still up, Marquetta.
Marquita. Really?
Marquita, I'm sorry.
It's okay.
Why are we doing cardiac troponin? Why are they going to draw cardiac troponin?
I'm thinking. You said, what are they looking for?
Why are they drawing a cardiac troponin?
Because that's the most indicative way of knowing, right?
Right, because it's the actual protein that's being released when what's happening to the heart.
When injury or...
There you go. Exactly. So that's the protein, and that's what's being released because there is injury to the heart. All right, and the next part of this was the myoglobin. The only reason they would draw the myoglobin is because why? That one goes up within the first hour, but is that one real significant to heart? No. All right. Let's see. These are people that didn't get caught on last week. Kayla, you're up. You with me? Miss Perkins, you here? Kayla? All right. Jennifer, are you with me?
Yes, ma'am, I am.
Okay, Jennifer. Now, this patient's having chest pain. Why is the patient having chest pain? What's happening?
You know, I'm not good being called out like this, but okay.
The only reason I'm asking, these are people that did not get called on last week.
I understand that. It's just not my forte. It's not my level of learning, but that's okay. Heart pain. You're asking me, what's the question?
Why do they have the symptom of chest pain? What's the problem? Why do they have chest pain if they're having angina or an MI?
Decreased oxygen to the heart tissue?
There you go. Because what's not getting there? Why are they not getting any oxygen?
Maybe due to low oxygen in the blood due to...
There you go. It's the whole purpose of supply and demand. There is not enough oxygen on the blood that's getting to the heart. It's not getting there, right? So you got a problem with supply and demand. That's the reason they're having chest pain.
Hey, Miss
Mason. Go ahead.
This is Kayla. I'm sorry. I was giving my daughter some medicine, so I didn't hear you calling on me.
Okay. Okay, Caleb, why would a patient, okay, so the other part of that one was shortness of breath, and it's the same reason. They don't have enough oxygen carrying capacity to the heart, so they become short of breath. All right, Kayla, so yours is going to be explain the benefit of each of the following medical treatments. Why is the patient put on initial bed rest?
To decrease the workload of the heart.
There you go, to decrease the workload of the heart. All right. And tell me why they're put on oxygen, Kayla.
To also decrease the workload of the heart.
That's right, because we have a problem with supply and demand, don't we? We have a blood that is not getting there, that has oxygen on it. So if we can get whatever blood is getting there, give them a little extra with a little bit of supplemental oxygen, then that is going to help the patient. All right. All right. Very good. Let's see. Merowit. Merowit, are you with us?
I have a question.
Yes, I'm here.
Okay, go ahead. Who has a question? Then Merowit, I'll come back to you.
Okay.
Does the oxygen also decrease the pain too as well?
Right, because it's given vasodilatation and they're getting more oxygen to the heart. Absolutely. So it's decreasing the O2 consumption and reduces pain because you're giving them more blood enriched with oxygen, right? Good question. Okay, Merowit, why are we giving morphine?
We are giving morphine like to help with their respiration.
Not the respirations. Why are you giving the morphine?
Okay, to reduce the catecholamine like the epinephrine and norepinephrine.
Okay, and what is it going to help with? If we decrease the circulating epinephrine and norepinephrine, what is it going to help with? What's it going to make those coronary arteries do?
Vasodilation.
Vasodilation, and it also helps with what other components of this patient? What are they in?
To reduce the preload. and increase the workload.
Yep, and because they're in pain and anxiety, we can help with that as well, right?
Yes.
Okay, very good. Rebecca, 2, how come we give nitroglycerin?
To vasodilate.
Yep, to vasodilate. If we vasodilate, what are we giving them?
More oxygenated blood.
Yep, more oxygen-enriched blood, absolutely. All right, very good. Good job. All right, and the last one I'll take. It wants to, oh, sorry, no, Desiree, you didn't answer one last week. You get one. You get the last one. Why are they doing the PCI or the percutaneous intervention? Percutaneous coronary intervention. Why is that being done? Desiree, are you with us?
Okay, sorry about that. My mic was, I couldn't.
That's okay.
Could you ask me the question again?
Yes, ma'am. Explain what's the benefit of doing the PCI or that percutaneous coronary intervention. What's the whole purpose of it? What's its benefit?
I'm gonna take a guess because I'm really not sure. I
You're
guess
sure.
I guess to just check the heart. I don't know. Like,
what's the whole purpose overall on an MI patient? What are we trying to do for this patient with any of these implementations we just talked about?
We're trying to increase the blood flow.
There you go. You're increasing the blood flow. Yep, you're trying to reperfuse it, right? You're opening it up. So that's what the PCI is for. Okay? All right, so we got the next patient. This is Mr. Preston. He's in the emergency room. Everybody should have this one with them. Everybody got Mr. Preston available?
Yes.
All right, so he's having chest pain. It's going to his jaw. He's diaphoresis. He's nauseous, and he's dyspneic. All right. What serum level tests were performed in the ER in helping diagnose Mr. Preston with an MI? Put your hand up if you know the answer. What are the things we're going to look at?
Troponin levels?
Okay, troponin level, absolutely. It's the most indicative. Yes, what else? If there's no troponin available, what else could they look at?
Is it the CKMB?
Yep, CKMB can be drawn, absolutely. And they may or may not do a myeloglobin, they may, okay? The next question is, he's a smoker. He's been smoking for 23 years, 1 to 2 packs a day. He has a history of hypertension, pneumonia, and pancreatitis. Which of these are risk factors for an MI?
Smoking.
Smoking and
hypertension.
Hypertension, yep. Mr. Preston appears to be short of breath after talking to you. To assist Mr. Preston's breathing, in what position will you place him? What are we going to do for him? Anybody that's short of breath, what can we do for him? What position?
And like Fowler? High Fowler?
Yeah, put him in a Fowler's position, absolutely. All right, the doctor has ordered the following: oxygen per nasal cannula and complete bed rest. And we know both of these are going to do what?
Decrease the workload on the heart.
There you go. Decrease the workload of the heart. Absolutely. Yeah. So if we decrease the workload of the heart, we've decreased its O2 myocardial consumption. All right. The doctor also ordered nitroglycerin and diltiazem. What actions do these medications have? What's nitro and diazepam going to do to the blood vessels?
Dilate them.
They vasodilate, absolutely. So how would it benefit? What is he going to get more of?
Decrease the oxygen consumption.
It's going to decrease the O2 consumption because what is he getting more of? if he's vasodilated.
More blood with oxygen.
There you go. More oxygen, more blood, enriched oxygen. Yep. What are some common side effects of these medications? They're both vasodilators. One's a calcium channel blocker. So, what are their common side effects?
Hypotension.
Hypotension. What's the most common one?
Headache.
Headache. Yep. Or flushing. All right. Then we got him on a low sodium diet, and his lunch tray arrives. He has French fries, ketchup, peas, and margarine. What would you remove from the tray?
Margarine.
And what else?
The French fries.
The French fries, because they're fried, and ketchup. It's got a lot of sodium. All right. All right, the patient, Dr. Carter has just explained the MI has affected his heart. He has asked you to explain what the physician meant by the terms depolarization, repolarization, and refractory period. All right. The only one we've really talked about was repolarization. Does anybody remember what that one meant?
Relaxation.
Relaxation. So depolarization is going to mean when the heart's doing what?
Contracting.
Contracting. Right. And the refractory period is going to be the period of the when the muscle is incapable of responding to a stimulus. That's all that means. Okay? And the reason they're wanting to know that is because what is the most common life-threatening complication that can occur to a patient after they've had an MI?
Cardiac arrhythmias.
Cardiac arrhythmias, right. And number 9 we won't do because we haven't talked about the ECG strip yet. Okay? All right, very good. All right, so we have Miss Sims, and she's having chest pain, it looks like, atypical chest pain. It's going to her left shoulder, down her left arm. She has a history of it. She says it increases with activity and decreases with with rest. She's a smoker, okay? She's 50 pounds overweight. Her rhythm looks good. She has nitroglycerin ordered. And 1 hour after admission, she has chest pain again, radiating to her left neck and jaw. The cardiac monitor is showing tachycardia because she's releasing epinephrine, so her heart rate is going up. And because her heart is agitated, she's having some premature ventricular contractions. Ooh, but look, her blood pressure is 100 over 70. Her respirations are 20 and unlabored. Her skin is warm and dry. What are we going to do with Miss Sims right now?
Place her on bed rest.
Put her on bed rest. What else are we going to give her?
Oxygen.
We want to give her oxygen. Absolutely. Yep. And also, what else do we want to get real quickly to see what's going on with her?
Baseline vitals.
Okay, get another set of vitals. And after I get another set of vitals, if her blood pressure, could we give her something? Her blood pressure is 100 over 70.
No.
Well, we could. We could give her nitroglycerin because we don't hold it until their systolic is less than what?
90.
90. So she could go ahead and have that, but that means I need to be on top of her vital signs, right? Now, will she need an ECG?
Yes.
Yeah, because we need to know, is this just what? Ischemia, or is this actual injury? All right. So then it's going to say, well, I just told you number 2. So what could be happening to her? She could either be having what? An MI or just angina, right? All right. How is angina differentiated from a myocardial infarction? How is angina different from an MI?
An MI is a partial or complete occlusion.
Okay.
Thrombus, and the angina is just reduced blood flow that causes ischemia.
Okay. But could angina be relieved with rest and nitroglycerin in the MI not?
Yes.
Yes. So that means with an MI, there's no relief with angina or rest. I don't care about number 4. That goes into a little more depth than we need. What are some nursing interventions that we can use? What's the first thing we want to put on her?
Oxygen.
Oxygen, yeah. Then we want to make sure medication, the other ones we can use are nitroglycerin, morphine. Are we wanting to give her maybe anticoagulant therapy and thrombolytic therapy and get her where? Where do we want to get her in 90 minutes?
To the emergency room?
No, she's already in the hospital.
The PCI?
We want to get her into the cath lab and get the PCI started, or she may need a what?
Bypass.
A bypass. There you go. All right. And what do we need to teach her when she's over all this? What does she need to stop doing, and what does she need to do?
Exercise.
Yep, she needs to exercise because she needs to lose weight, and she needs to quit doing what?
Smoking.
Yep, absolutely. All right, good. All right. So let's move on. We got a few minutes. We're not going to finish this, it doesn't look like. All right, so the next thing we want to talk about is PAD. Well, maybe. Let's see.
Did she get kicked out?
My computer froze up again. Sorry about that. All right, so the next thing we want to talk about is PAD or PVD. When we talk about PVD, if you look at your sheet, what are the 2 components of PVD? What are we seeing? What are we going to talk about with PVD?
Arterial and venous.
Yeah, we're going to discuss arterial and venous, and the big one we're going to talk about a whole lot is going to be venous. Arterial. I'm looking for my PowerPoints. They have disappeared. There we go. All right. So we're going to talk about arterial and venous. That is going to be what PVD is. Okay? All right. So this is now, when we talk about PVD, we are going to be talking about when it comes to PAD, we are now talking about peripheral vascular disorders that are affecting the lower extremities, like the legs mainly, the feet, or maybe the hands, okay? So that's what we're going to look at here. Now, when you have this, it's going to be the same similar problem as when you have ischemia in the heart, except now it's going to be in the lower extremities. So in other words, we got a problem once again with the oxygen enriched blood flow getting to the lower extremities for some reason when we see PAD, okay? Venous is going to be when we have a problem of returning the blood from the lower extremities back to the heart because something is wrong with the valves in the legs, okay, in the veins of the legs. So that will be our problem with venous. It's going to be there's some kind of incompetency in the vessel, the vein itself with the valve. So we see this very commonly in our older adults and diabetics. So we're going to see this more commonly in our patients that are older and diabetic because we have that decreased blood flow, and it can be either arterial or it can be venous. Okay, so PVD may be either arterial or venous in origin. All right, so keep that in mind. Now, when you're doing your venous and your arterial, you want to compare them. You want to look at them. So when you got a patient that has a problem with their blood flow to their feet, if they are diabetic or elderly, once again, it's the same goal as a patient having MI. So we want to do what? What do we want to make sure is getting down there to that extremity, just like we want it to get to the heart?
Oxygen.
Oxygen. All right. Say though, for some odd reason, the patient develops a arterial thrombus. Okay. If they get a blood clot, just like they do in the heart, we have cut off the blood flow very acutely, just like with an MI. Okay. But now it's probably going to be in the lower extremity. All right. It's going to do the exact same thing as if a patient is having an MI. In other words, it can cause injury. It can cause death to the lower extremity. Okay? So what do you think the patient is going to exhibit with when they have this abrupt stop of blood flow even to the lower extremity from a blood clot?
Pain.
Pain, absolutely. Yes. And so they're going to have pain. So in other words, usually there is an abrupt onset of symptoms when they have an acute arterial occlusion. So when we look at this arterial occlusion, what are some signs and symptoms that will tell us this patient is having a acute occlusion besides just the pain? What else is going to tell us there's a problem?
Pulselessness.
Okay, they can have, we got pain, they can have pulselessness. What else can they have?
Paresthesia.
Numbness.
Paresthesia, yep.
Pallor.
Pallor, which means very pale, right? What else is another one?
Paralysis.
Paralysis, and somebody was fixing to say another one.
Oh, the poikilothermia.
Yeah, the poikilothermia, where the extremity is not the same as the room temperature, right? So anytime you have a arterial thrombus where you all of a sudden have an occlusion, just like you do with an MI, the patient is going to have pain because this is an abrupt onset, okay? So they're going to have pain. Then we're going to notice they're not going to have any pulse, right? Then we're going to notice that the patient is probably going to have this poikilothermia, where the temperature of the extremity is going to change. Then we're going to notice that they're going to start saying, oh, it's numb, it's tingling, right? And they may actually lose function of that extremity as well. But we know that if they have a thrombus, an arterial thrombus, and no blood is getting there, we know it's going to lose its color. So it's probably going to become very pallor in color as well. So with an abrupt occlusion from an arterial thrombus, you will see the clinical signs of the 6 Ps that will develop with this patient. So this is a sudden, abrupt onset of symptoms. And those are the 6 symptoms that you are going to see develop when it is an arterial thrombus that is very quickly. Okay? And it's the same thing as if a patient's having a a quick MI, right? Because don't they have the pain?
Mm-hmm.
Yes. Yes, they do. Okay. We're just thinking of a different area of the body. We're just looking at the lower extremities now. So we see those 6Ps develop. All right. So what are they going to do for this patient? Well, it's almost very similar when you look at this as if you have a thrombus in the heart. All right. Because if they get a clot that develops very rapidly and we're not getting any blood flow, we need to reperfuse that area very quickly, because if it's not reperfused, what's going to happen to that area?
Death.
It's going to die. It's going to necrose. It's going to become gangrene, just like the heart when it loses its myocardial contractility ability. So once again, we still got the same concept of supply and demand, don't we? So this patient is probably going to get a thrombolytic, just like with our MI patients, because most of the MIs are from a thrombus, and this is an arterial thrombus. So they're going to get a thrombolytic. And what is that thrombolytic going to do to that blood clot?
Dissolve it.
It's going to dissolve it, blow it up like a piece of dynamite, isn't it? Then what they'll do is they will also put them on anticoagulant. What anticoagulant would they put them on that's IV? Heparin, absolutely. And what they're hoping for is they're able to burst the clot to where they don't have to take them and do a thrombectomy, where they don't have to go in and actually open them up. So what they can do is take them to an area called special procedures and administer the thrombolytic. And hopefully within several hours that this blood clot will burst. And they'll be able to only do it that way, and they don't actually have to go to surgery and have to have the thrombectomy. So that's the nice thing. A lot of times when you have a patient, when they come in and they have this abrupt arterial occlusion from a thrombus, give them the thrombolytic over time and try to burst it so they don't have to go to surgery, and put them on the anticoagulants to prevent further formation of clots. So if they are on heparin, what would be your lab that should be monitored frequently on this patient? If they're on the heparin.
Platelet count?
We can monitor the platelet count, but which one do we want to monitor for sure with just regular heparin?
Is it the APTT?
The APTT, yes, the APTT, because it's actually going to deal with the partial thromboplastin. So we definitely want to make sure we're on top of the APTT. What would be your antidote they should have available for us if we had a patient was on heparin?
Protamine.
Yeah, protamine sulfate, right. So for the lab, we want to make sure they're looking at that APTT, which is activated partial thromboplastin time, okay? Activated partial thromboplastin time, APTT. Normal is 30 to 40 seconds. Now, what do you think this person's going to go home on if they're having blood clots developing in their arteries as an anticoagulant?
No.
As an anticoagulant, what do you think they're going to go home on?
Warfarin, Coumadin?
Yeah, they may go home on warfarin, or they may go home on that low molecular heparin as well with this patient. So if they go home on the warfarin, though, what lab are they going to monitor kind of closely on that patient if they end up on the warfarin and they go home? Yeah, the prothrombin time, the PT, absolutely. because we have Eliquis, but that's used for atrial fibrillation. But this one is going to be mainly used for patients that maybe have some type of arterial occlusion, blood clot formation with the extremity, that they'll get the warfarin. Please remember too that because warfarin is PO, it's going to take it somewhere between 3 to 5 days to become therapeutic. So that means the patient will not come off of their heparin or their low molecular heparin, their enoxaparin, until the warfarin becomes therapeutic. And that's the reason they are going to monitor their INRs when that becomes therapeutic, or their PT. Okay, so they'll keep them on the low molecular heparin that they go home on for about till that warfarin becomes therapeutic. All right. Now, the first disease disorder, that was just talking about an occlusion, an abrupt occlusion, like somebody has a massive MI all at once. But some of these patients, when they're diabetic and they're elderly, as they get older, they start having problems with their arteries. And so we'll see some disorders of actual where they have arterial circulation problems. It could be due to atherosclerosis, which is the number one thing that we see causing peripheral arterial disease, that can actually cause arterial circulation decrease. So in other words, when you have PAD, they still are not getting what when they need it.
Hi, this is Miriam. I had called earlier.
The
I
supply
wanted
and
to
demand of
know the
oxygen.
information
Yeah,
about
their
let's say
supply
if
and
you
their
want to
demand is
transfer from
out
one
of whack
ticket to
too
another.
here with your PAD, because the arterial circulation is decreased. Maybe they're diabetic and they
Okay,
have
so you
been
have
leaving
to.
their
So
sugars
let's say
high,
like if you're
and it
accepted,
has
do you have to
damaged the
repeat? Let's say like I have done the
elasticity
first
of that
semester
blood
and I have passed.
vessel,
Will I
and
have to
so
repeat
it's
it?
narrowed it down, and so they don't get enough blood flow there either. So this one, once again, PAD is going to be
Okay.
that supply and demand, and so we'll see that. And once again, that's going to answer. Well, I just answered number 4 on your occlusive disorder. What is the leading cause of PAD? It's atherosclerosis. Then it asks you in pathophysiology of PAD, the cause is an imbalance in supply and demand for oxygen. It's the same
Okay.
concept as if a patient is having
Okay. Thank you
ischemia
so
in the
much.
heart. It is just a different area, okay? A different area is all we're seeing, but they're having the same symptoms because I still don't have that oxygen enriched blood flow, so they can develop ischemia in the lower extremities. That's what PAD is. And its main cause, once again, is atherosclerosis, the plaque, because we developed that over time. And it's impending what again? What's it impending? What are they not getting enough of?
But more.
The blood, oxygen enriched blood flow, yes. And it's always going to be the area distal, okay? In other words, further away it is, that's where we're going to see the actual symptoms occur. Now, one thing that will help these patients, though, because they're older, this is peripheral arterial disease. This shows you good blood flow. And then you can see as you get older, when you get atherosclerosis, how plaque can narrow the blood vessel. So this kind of shows you we're not going to have as much blood flow. So when our demand goes up, when does our demand go up with our lower extremities? When we're doing what? When is this patient going to have pain?
Maybe when you're working out or you're cold.
No, just in general. What do we do every day when we get up?
Standing.
Not just standing, but what are we doing?
Walking.
Walking, right? Because therefore, if I walk, did I increase my demand? But if I have all this plaque, am I going to have the supply? Absolutely not. So that's when they're going to develop the pain. But there's some things that can actually help with this, and it's a compensatory mechanism that develops over time. And it's going to be that one right there. What's it say? What's developing over time from walking?
Collateral circulation.
Collateral circulation. You're going to do the exact same thing as you do with the heart. It's going to be because you have a partial occlusion and because you still need to supply that area, that these little branches are going to grow off and give you some extra circulation into that area because you're having this chronic ischemia. So you've got this lack of blood supply, oxygen enriched blood, so therefore it gives them ischemia. And of course, if this is not taken care of, the patient will develop ulcers in their feet, arterial ulcers. They can develop gangrene, which that means the extremity starts to die. And if it does, what are they going to do if your foot dies or your leg?
Amputate it.
They're going to take it. Yep, they're going to amputate it. So this is showing you collateral in the leg. Here's this occlusion where this patient is having chronic ischemia. And so now, because our body is a miracle worker, it has now developed this collateral circulation to try to keep that lower extremity still alive. So that's the whole purpose of collateral circulation, is to try to keep things alive distal of the occlusion. So that collateral circulation is going to be very, very important, because the body is not able to meet that demand all the time, and so we develop the collateral circulation. So if we don't have that though, so we haven't built any of that up, that's when we're going to see more problems develop with the ulcers. We're going to see more problems with the gangrene setting in. We're going to see more death of the extremity, and then they will lose that extremity eventually. So our signs and symptoms, once again, some of these people might not have any pain at all, because who are some of the patients that have very low thresholds of pain that sometimes don't feel the discomfort? Who has neuropathy?
Diabetics.
Diabetics, yeah, and this could be very dangerous for these patients. Some of them may actually have what we call where they'll get up, start walking, and then when they stop walking, this is the most common symptom that we see with PAD, is I walk and I stop and the pain goes away because the supply and demand are being met at that point. But then I start walking, I have pain again, and then I rest. What kind of pain am I having that's associated with activity or exercise?
Intermittent claudication.
Yes, that intermittent claudication. So that's what I'm describing in number 6 on your PAD worksheet, is where they will actually have pain that's associated with activity or exercise. And that is a very common symptom that we will see with our PAD patients. So that's the one you definitely want to remember. So that pain in that extremity is going to be due to the activity, okay? That is going to be due to the activity, because the ischemia develops because supply and demand is off once again. Now, the other things that we may see happen with these patients, because you're not getting enough oxygen-enriched blood flow, they will have hair loss. The skin will become very dry. The toenails will become very thick. Now, the main things that you want to remember is that intermediate claudication, because it is the most common pain problem that we see with these patients. But the other thing you want to think about is, what is the temperature of the foot going to feel like? What is it going to be if you don't have any arterial blood flow? It's going to be very what?
Cold.
Cold. It's going to be cold. It's going to become cold. All right. So think about this. So how do we want to keep their feet? Do we want to keep their feet down or do we want to keep them up?
Elevated.
Think about if you elevate their feet.
Down to promote blood flow.
Yes, you want to keep them in a dependent position, keep their feet down. And when we do that, though, if you look at their feet, a lot of times they'll get this real red look, or they may become what we call, they'll kind of be spotty. And it'll look like they have areas that are kind of paler, and then they'll have purple areas or blue areas. That's called mottling, Mottling. But the thing is, when you put their feet up, they become what?
Pale.
They become very pale because what's not getting to them at this point if you put their feet up?
Blood.
Blood. They are getting no circulation, so that's the reason we like to keep them very dependent. So the other thing that's going to tell you this patient has actually got a PAD is what's going to be diminished or absent distally because it's arterial.
The pulse.
They're not going to have a pulse. Absolutely. It's going to be diminished or absent. Yes. And here's just a picture of somebody that maybe has some PAD. That's some necrosis. Those toes are going to fall off eventually. And I have seen that. We had a patient, I'm fixing to let y'all go, had a patient that he had diabetes and he had PAD. And his daughter would bathe him, and periodically she'd go, oh, his toe's laying over there on the bedside table. And we'd have to get the toe. So we're a little behind, quite a bit behind. So we're going to have to really speed up on Wednesday. And so we'll finish this chapter, and we'll start chapter 25, and I'm going to try to complete it. Okay? So be prepared. Go ahead and listen to your PowerPoints for chapter 25 before Wednesday. Wednesday is a 6-hour clinical day with a lecture in the afternoon. Any questions about today's lecture?
Can you post on D2L where we need to be this week and when?
Oh, yeah, I will. I will. You know you got to be on campus for clinical, right? If you're in A, where are you at?
With you.
With me, yep. If you're D, where are you going to be?
With you?
With me. Group D is going to be with me, so you're going to be over by the Sims lab in third trimester classroom, I think. We'll have to see. We'll have to figure it out. And then the other groups, B and C, will be with Miss White in classroom 2. Okay?
So we're going to be in classroom 2 from 6:30 to 12:30. Do we have to bring our laptops? Are we just going to get...
No, you will need to bring your laptops. I'm going to put that in there. You're going to have your laptop and earbuds because you're going to have an assignment that's going to be in D2L that you have to complete and drop before you leave or have it done by 4 o'clock.
Got it. Okay.
Okay.
Does Group D have to wear their clinical attire?
Everybody has to wear clinical uniforms because it is a clinical day.
Okay.
Uh-huh. Okay, good question.
Miss Manners?
Yes.
Did you happen, and maybe you've already posted it and I missed it, did you happen to put the time down for when we're going to be on campus for the next math exam?
Yes, I posted it, but it's been a while. It's the same as we did the last time, 0745.
Okay, perfect. Thank you.
Yeah, uh-huh. All right, any other questions? All right, y'all free to go. Thank you. We'll do some more interacting.
Miss Manners?
Yes, ma'am.
I have a quick question. Also antidysrhythmic is called potassium channel blockers, right?
Yes, antidysrhythmic